I'll go ahead and get started. I'm Courtney Wusthoff. I'm a pediatric epileptologist from up at Stanford, and my area of focus is taking care of babies, newborns and infants who have seizures. And sometimes that's newborns right after they're born when they're in the NICU, and sometimes it's babies who are a little bit older, weeks or months old, as they come in to see us in the hospital or in the clinic. So what I planned on doing is just taking maybe 10 minutes to give an overview of the things I think about when I'm taking care of babies with seizures. And I wanted to leave most of the time for questions because I want to talk about things that are relevant to you guys. And if you have questions as I'm talking, please interrupt. We're a small group, so this can be really informal. So when I say that I take care of seizures for newborns and for infants, that's actually a kind of different group of children. Most newborns who have seizures, if you have a family member or a loved one who had seizures when they were first born, most of the time that's because of something that happened at that time. They call them symptomatic seizures. And that can be because a baby had a stroke, that can be because of an infection, that can be because of not getting enough blood flow or oxygen to the brain. And so for about 85% of babies, newborns who have seizures, it's reflecting something else that's going on. For older babies who have seizures really in the first 2 years, it's much more likely that they have a genetic epilepsy. It's not always the case, but that's the most common reason to have seizures when you're an infant. And so they're kind of two different groups of patients because the things that you're thinking about that go along with the seizures will depend on what's causing the seizures. But because I like taking care of the little ones and a lot of the services that we provide are the same regardless of what the cause is, that's how I ended up with that particular area of focus. I think the kinds of questions that are applicable to both groups, the things that I hear the most when I'm meeting families and taking care of babies, the question of why did this happen always comes up. Because it's unusual for babies to have seizures, and I think we're getting better and better at answering that question. It used to be that babies who had seizures, there was this sort of shrug and, well, we don't know what'll happen, but we'll see. Now we have much better genetic testing, and so for babies where there's not an obvious cause, like a stroke or an infection or something like that, we can find the answer about half the time using a genetic test. And so that's one thing that I talk about with families is that if you were told when your baby was first born, this just happens and we don't have any idea, it's probably worth digging a little deeper, going back now, because what we have available to us now is better than it was even 5 years ago. Another question that often comes up is what's going to happen long term? Are the seizures going to harm my baby's brain, or are the medications going to harm my baby's brain? And both of those are very legitimate questions. The thing that most strongly impacts how babies do later on growing up is the cause of the seizures or of the epilepsy. And so you can imagine if it's a cause that's something that can be treated, then that's a situation where you can be really optimistic that you'll be able to get things under control with the treatment. Some of the other conditions that might have other consequences besides just seizures, for example, a stroke, then you might need to look at more specifically what the situation is to get a sense of what other things you have to look out for going forward. Having lots of seizures over and over is obviously not good and not something that anybody wants. And we do our best to control them with the medications. I don't worry about single seizures, 2-minute seizure, a 5-minute seizure causing permanent injury to the brain. I do worry about kids who are having dozens of seizures a day that are uncontrolled over a period of years. I worry about that changing the way that the brain works. I worry about seizures that are longer, 30 minutes, 60 minutes long. I worry about that causing changes in the brain itself. But the flip side of that is always the medications. And I hope that we're entering into an era where there's more medications available for the little ones. It's been the case for years and years that phenobarbital was the only choice. And there's still a lot of people who are not comfortable using medicines other than phenobarbital in kids who are less than 2 years old. And it works. It's, of all the medicines that are available, it's the one that actually has been shown to work the best for newborn seizures, but it's got a lot of nasty side effects. And so we do still use it when we're trying to get seizures under control. For example, right in the hospital when the seizures had first started, and there's a lot of them happening back to back, it's a good medicine to try to get things under control. But it's not a medicine that we want to keep going for weeks or months or years if we have some other choices. Thank you. Oh, they're purple. Yeah. So phenobarbital is still the first-line medicine for newborn seizures for that reason, because it works, because we've been using it forever, so we know what to expect from it. But it's not the medicine that anybody really wants to continue in the long run if you need a medicine for the long run. And there's two things that go into that. One is, I think we're taking away medicines. We're stopping medicines sooner than we used to. So because most babies who have seizures had their seizures because of something happening right then, like an infection or a stroke, once you get through that period of injury, those days or weeks, depending on what it is, you often can stop the medicine, and the seizures might come back, they might not, but many children are able to continue without seizure medicine, either ongoing, or they can go for months or even years without seizure medicine. There's not really any good proof that continuing a medicine will make a difference of whether or not the seizures come back. And that's something that's different for newborns than it is for other kids, where we have a lot more information about how long you have to use the medicines and what to expect. So I think that's something that's changing, is that we're quicker to try to stop medicines early to see if we can avoid some of those potential side effects and the long-term worries about seizure medicines. I think the other thing that's changing is we have now new seizure medicines that have been around for at least long enough that we've all used them in adults, and we've used them in older kids, and then you start to use them in the preschool kids, and as you get more comfortable with them and know what to expect, we get more experience using them in the babies. And so there are a few medications that are available to use for babies. None of them are FDA labeled for use in infants, and they probably won't be, but it's still an option, and I think often a better option than continuing something like phenobarbital if you do have to be on a medicine long term. So that's a pretty general overview, but I think that those are the features that bring those types of diagnoses together, even though they come at different ages and from different causes. And certainly the most common questions that I get asked when I'm in clinic. Rather than me just sort of talking, I wonder if you're comfortable, if folks would talk about what questions they have on their mind, or if you have any particular experience with a baby or a toddler who has epilepsy. I won't pick on anyone. Yeah.
So my niece has a brain deformation called pachygyria, which has caused infantile spasms, and she'll go through bouts of seizures. About a week ago, she had a day where she had 15 seizures, but she went a month and a half without any seizures. So it was like all kind of hit all at the same time. My question more has to do with the infantile spasms and like the transition into epileptic spasms.
Yeah.
If she's had, so she went in for an EEG probably about a month ago.
Yep.
And they said that the brain waves, although they don't look normal for like general population,
Yep.
they look really good for her.
Yeah.
And the spasms, they don't see them there anymore. How long should my sister or brother-in-law keep her on the Cerebral? Is there like a certain amount of time? Is there, so like wean her off of it if it's not gonna, if the spasms aren't there anymore? Or is that a situation where the Cerebral, which is meant for the infantile spasms, should she just remain on it until like for a certain amount? I don't know.
Nope, those are
a time question for how long should she remain on Cerebral?
Yeah.
To keep from relaxing?
That's a good question. I'm just writing stuff down so that I don't forget the things I want to cover. So infantile spasms is a particular type of epilepsy. It's an epilepsy syndrome that usually comes around age 4 to 6 months. It can start up later in infancy, but that's the peak time of onset. It's characterized by having a certain EEG pattern called hypsarrhythmia. The spasms themselves, which usually will look, sometimes parents will say, oh, I just thought it was a startle or a little sit-up. The arms and the legs might go up. There might be flexion of the body. They tend to come in clusters where you won't have any for hours, and then there will be a few in a row, and the baby will cry. They tend to happen most often when babies are waking up, and that can be from overnight or from a nap. And it's a tough epilepsy because it's often associated with developmental regression, and particularly if you can't get the spasms under control or the hypsarrhythmia under control, then developmental regression there's a much higher risk for that. So there's a couple of choices for treatment, and there's a couple of ways to know if your treatment is working. I think one thing that's underappreciated about infantile spasms is it's not enough to just make the seizures go away. You have to make that EEG pattern, the hypsarrhythmia, go away. And just like you said, it might not make the EEG perfect, and you don't really ever expect that you're going to make the EEG perfect, but you have to get rid of the hypsarrhythmia. And a trap that sometimes as providers we fall into is that you just do like a 30-minute EEG. It might look good just during that 30 minutes, but hypsarrhythmia tends to come out when kids are in deep sleep. And so if you just do a short EEG that lasts 30 minutes while a baby's awake, or maybe they fall asleep but light sleep, you can miss the hypsarrhythmia because some kids will come in and out of it throughout the course of awake and asleep in a day. So one thing to know in trying to decide, like, how long do we treat this? Are we done yet? Or are we still worried about a relapse? Is making sure that the EEG is completely free of hypsarrhythmia. And so when I'm taking care of patients, if they're still having spasms, I know we still have some work to do. If I can get that 30-minute EEG and it still shows hypsarrhythmia, we still have work to do. But if the spasms have stopped and the hypsarrhythmia has stopped on a short EEG, it's often worthwhile to do an overnight EEG to make sure that I see the brainwave pattern when that baby's in deep sleep. If an overnight EEG isn't possible for whatever reason, sometimes I'll have babies come and sit for 6 or 8 hours in the EEG lab because at some point they'll probably fall into deep sleep. And that's really the safest way to know that the hypsarrhythmia is completely gone.
She said, I want to say she said 4 72-hour.
Okay.
36 72-hour EEGs. I believe 2 of them were like emergency based because she was having really bad spasms. But this last one was, I believe, 72 hours, and they let her go early because after 48 they didn't see the hypsarrhythmia.
That's good. That's a good sign. And so the best case scenario is that you have a treatment and it controls the hypsarrhythmia and it controls the infantile spasms, and then you hope that they don't come back. And the question of how long to treat is a really valid question. Some of the treatments we use for infantile spasms, you have to stop pretty early, like steroids, because the side effects are just going to get nasty if you keep treating for a long time. So for kids who are on steroids, that's the treatment we usually stop the quickest because we want to get rid of the side effects as soon as we can. For vigabatrin, there's not a hard number for how long do you continue this medication after you've gotten rid of the hypsarrhythmia to make sure that it's really gone. I think most people will usually continue it for a couple of months, but I'll be honest that that's a guess. We don't really know for sure if you stopped it at a month, is that any different than if you stopped it at 3 months or 6 months. We do know that with vigabatrin, the potential side effects, the adverse effects, go up the longer that babies are on the medication. The one that people hear about the most is it can cause changes in vision, and that's certainly a higher risk the longer that a patient stays on vigabatrin. So for kids who are on vigabatrin for less than 3 months, the risk is relatively low. For kids who are on vigabatrin for more than a year, it gets up in percentages. And so for me, that's why I usually will keep kids on for about 2 or 3 months, and then I'll try to take away the vigabatrin if everything's been going well. Sometimes what happens is the hypsarrhythmia gets under control, the spasms go away, and then another seizure type comes. And that's part of how epilepsy can evolve as kids get older. Infantile spasms, like the name says, it just happens in infants. But once kids grow out of it, if you will, they can go on to have other kinds of epileptic spasms. And those can look just the same from looking at a child, but the EEG pattern is a little different. It's of course frustrating. You don't want to have a new seizure type to deal with, but if there's anything that's good about it, it's that there are other treatments that can sometimes work for epileptic spasms that aren't useful for infantile spasms. So even if you've gotten out of the infantile spasms range and now there's epileptic spasms to deal with, you do have some more tools in your toolkit than with infantile spasms, where there's really only about 3 or 4 treatments that have been shown to be effective. Now, vigabatrin can work for epileptic spasms too. I get self-conscious. um, but because of the side effects, usually folks will try to switch to a different anti-seizure medicine rather than just keep vigabatrin going for the long run. In a case like a gyral malformation, you're looking at epilepsy that's going to be long-term, and so you got to choose a medicine that's going to be something you can live with. That's probably not going to be vigabatrin as your first choice. If you end up there, you end up there. But after a couple of months of no hips arrhythmia, it's a reasonable question to try something else.
Yeah, I asked last year about it because, so my niece is 2.5, so she's finally getting out of that stage. And last year, my brother-in-law and my sister were, like, swore they'd keep her on her for as long as she could, like 8, 9, 10, like they'd be, like, fight the doctors to keep her on her so that it didn't happen again. But, and one of the doctors said that there was no, like, as long as there's no, because she has CBI, so we don't know what she can see.
Yeah.
The doctor was like, well, vision's the only side effect, so it's like, if they're that adamant about it, and it's keeping the hips arrhythmia at bay, like, we could do it for that long, but it's not like, it's very similar to what she said, it's not the first choice.
Yeah.
And the seizures that she's having now are different than the ones she had when she was young.
Yeah.
So we're trying to adjust to what they look like and trying to figure out how to take care of them now.
It's a moving target. You know, just when you've got the infantile spasms under control, now you have this new seizure type to try to sort out. I would say that the vision loss is the thing that people think about the most with vigabatrin because it's, you know, in this big black box and you have to sort of sign away your life to start taking this medication. And that type of vision loss is changes in the retina, like in the eye itself, that can affect mostly peripheral vision, which can be relevant for things like driving. But as you said, if there's already visual impairment, that might be less of a concern for a particular child. But it's not the only potential side effect with vigabatrin. The place that I run into trouble, actually much more often than vision, is that it can be sedating. That's true at higher doses rather than lower doses. And I often find myself talking with families where we're in this bind of, this is okay, but we wonder if we were on a different medicine or a lower dose of medicine, would she be more alert? And so that's one thing to consider. And it also can reduce overall tone. So for in children who have low tone, like in cerebral palsy, if they're having trouble supporting their trunk, that can be a problem. I've also seen it be associated with drooling. And for all three of those things, the alertness, the tone, the drooling, it's hard to know for sure how much that's the vigabatrin versus something else. But it's another reason why it wouldn't be the first thing that I went to if I had other choices.
She might have CP. I haven't gotten that far yet. But she can't walk, she can't talk, very low muscle tone.
Yeah.
So, and she drools a lot.
Yeah.
So
it might
could be a combination of both.
Yeah.
Okay.
It might be worth thinking about in the long run, what are some other choices that might be a better fit for her.
Okay.
Yeah. And you mentioned something about, you know, we don't know if she has CP yet. This is another thing that I talk about with families of babies who've had seizures because very often there are other sorts of brain conditions that go along with it and a high risk of having cerebral palsy. For folks who live in California, how many people live in California? Okay. So I think there's sometimes, in general, a fear or a reluctance of putting the cerebral palsy label on a child. And all cerebral palsy means is that you have a brain condition that makes it hard to control your movements. And so if you have pachygyria and you can't walk, for some sort of systems or definitions, that counts as CP. The old way of thinking was that you can't ever diagnose it before somebody's 3 years old because there are kids who will start out with some motor delays and then grow out of it by the time that they're 3. But there's a lot of kids where you know that that's just not going to happen. And so I think it's only fair to be honest about what you expect. Are we waiting to make this diagnosis because we think it's going to go away? And if not, are there any benefits to making the diagnosis? Sometimes for insurance and for accessing services, that label, the CP label, can be really helpful. And so if it's something that you've been wondering about, I think it's great to ask your neurologist, does she have this? Because if it's there, whether you call it CP or not. And if it's there and you call it CP, sometimes it makes things a lot easier to get services for things like physical therapy or seating or occupational therapy, that sort of thing. So CP for the babies, a lot of folks will not want to use the CP word, but it can make life a lot easier once the diagnosis is it's in the chart, things go through faster.
Just because from Valley Children's.
Okay.
So for CCS for you guys, do they require you to do an MRI in emergency field?
No.
So in our area, our CCS fights us on requiring MRIs for a CP diagnosis.
Wow.
So I just wanted to make sure, like, because we're obviously fighting them on a daily
Yeah.
basis for that. So it's good to hear you say.
That's not cost effective.
It's not, exactly.
Yeah.
So I mean, that's the argument we have. It's
Yeah.
like, especially, when hearing him talk about his knees,
Yeah.
I'm like, if that's a classification that would fit and would help with early intervention with extra
Yep.
services and all of that,
Yeah.
it makes sense to have that without having someone fighting back and saying, oh, well, you're just slapping a diagnosis on.
Right.
So then they come back and argue with us.
Right.
So it's interesting to hear that.
Yeah.
And I was just curious.
So the place.
Your area, if that's CCS, actually.
I mean, so California Children's Services, who in California provides most of our patient services, PT and OT, they have on their website their list of qualifying diagnoses, and none of those are MRI dependent. And it's often easier to get kids in on the basis of just an exam when they're younger. So if they have persistent reflexes, if they have spasticity in the extremities, that kind of thing, that I always am able to get in. I very intentionally use the exact wording that they use on their website, and I bold it and underline it. The one place I have sometimes had to fight, and I don't always win, is when the trouble with motor control is due to like a genetic condition, because then it's not an acquired brain injury, and sometimes they will specifically exclude kids who have a genetic diagnosis. So I don't know if that's their rationale for requiring an MRI, is to prove that it's acquired brain injury.
We have a harder time, like, with our spastic CP kiddos. That's easy. Well, that's easier.
Okay.
It's with our kiddos that are a lot like looser.
Yep,
that
yep.
we have an issue
Yeah.
with fighting them.
Yeah.
On those particular.
Yeah. So the place that I've picked up the most sort of extra ways in is if they don't have spasticity. That does make it harder to document an exam that'll be recognized. But if you look hard enough, many of them will have fluctuating tone, and you can get them in through the dystonia pathway. And if it's fluctuating, maybe I see it in my office today, even if it wasn't seen by somebody else. And so it's consistent, even if it hasn't been documented at every single visit. But I do have to jump through a few more hoops in my note to lay out, this is dystonic CP with fluctuating tone. I'll describe what I saw and how I assessed it. And that can sometimes get around the spasticity issue. Yeah, it's tough. Yeah. Yep. For the older kids, ataxia is sometimes another way around it. For the little babies, sometimes that's harder for me to convince them. But by 2.5, yeah. Does anyone else have any questions? Wow.
Not one abnormality. He'll go for 6 months without a seizure, and it only happens the time he falls asleep within the next 2.5 hours. It's the only time it's ever happened.
Mm-hmm.
And it's really sound asleep.
Mm-hmm.
Otherwise, he's totally a normal child.
Hmm.
Is this Anne told that you're probably not going to outgrow this?
Hmm. Did they ever find a reason for why he had seizures? No. Okay. That's tough. Oh, good. Okay. Normal. Okay. It's tough, not specific to him, but in general, at centers who do epilepsy monitoring, there's about 20 to 30% of kids who come in who've been told that they have epilepsy or seizures, and we find out that the thing they thought was a seizure was not a seizure. So I think it's appropriate to look really, really hard. 2 weeks is a long time, but it's appropriate to look really hard to make sure that you understand what you're treating. And it's so frustrating when you can't capture the thing. Yeah, I bet you're even more frustrated. Yeah. There's a couple of ways to go at it. Sometimes you never catch the thing, but there's something else going on where you're pretty convinced that this is seizure and epilepsy, and so people will still call it seizure or epilepsy. And so if the MRI showed something that was a predisposition to seizures, if there was a known genetic condition that predisposed to seizures, then it's a little easier because you say, well, we never caught the thing, but we know that, yeah. But for kids who don't have any of that, and you really are just having these really infrequent events, because no one wants to call it a seizure until they're sure, you're sort of left in a bind of how to come at it. And I think most of us do the same thing of trying to catch it on a video EEG if we can't. If we're unsuccessful, then you're sort of left with, you can treat it and see if it goes away, or you can not treat it and see if it gets worse. Mm-hmm. Mm-hmm.
Residual after, and they're shorter.
Mm-hmm.
And it's not like just shaking.
Yeah.
And he does have them next morning. He'll have maybe weakness.
Uh-huh.
He did have some speech delay, but it catches up within the day.
Uh-huh. Uh-huh. Yeah. I mean, that sounds like a seizure. The being afterwards sort of post-ictal and confused, and the fact that it got better with medicine. And sometimes that's all you're left with, which is really frustrating. But I definitely have patients like that where, we go years, and maybe sometimes we do finally catch the thing, and it's almost like a relief of, I'm so happy he had a seizure while he was in the hospital. But other times you never really catch one, and it's certainly possible. It's rare, but it's possible. Yeah. Mm-hmm. Yeah. So in that situation where we never found a reason for it, we never caught one on EEG, the EEGs were always normal, I do tend to go back to, if there's no thing for 2 years, let's try to take away the medicine. And if the things are coming, it can be helpful later when kids are older to try again with the EEG. There's sort of these periods in brain development where your brain just changes as everything changes, and you might have a change in the way the EEG looks that helps you understand one way or another. So sometimes that's just the changes that happen over the neonatal period for newborns. Puberty is another time where everything that was stable before is now completely thrown up into the air. And so hope that it's the first thing where they just stop for 2 years and you get to say, well, let's try to take away the medicine. But especially if you keep having to add medicine and you're giving a second medicine and they just don't quite go away, sometimes you do luck out with a later EEG when kids are older because their brains have changed since the beginning. But that's tough. That's a tough situation. What do you guys do?
I think we wait for 2 years. If they don't have any symptoms in 2 years, we try to
Yeah.
and see if the symptoms come back, or sometimes they don't. So
Yeah. Where you get lucky.
Yeah, then we get lucky.
Yeah.
Yay.
Yeah. Any other questions that anyone has?
You mentioned this arrhythmia.
Yeah.
Happens during deep sleep.
Yeah.
How does that show up? EEG or MRI?
No, it's on the EEG, so it's a pretty distinctive pattern. So if a normal brainwave pattern sort of has an expected rhythmicity to it, and it looks about the same all throughout the brain. Hypsarrhythmia, the thing that makes it hypsarrhythmia, is that it's very high in amplitude. The lines are chaotic. There's no organization to them. They have a lot of sharp waves inside the pattern. So if you catch it, if you're recording when it happens, it's pretty hard to miss. The problem is that it's for most kids who have hypsarrhythmia, they don't have it 24/7. They'll sort of go in and out of it depending on whether they're awake or asleep. And so when your suspicion for it is high, or if you're trying to follow up somebody who you knew had it before, you got to make sure you catch them in deep sleep to know whether it's totally gone or not. Yeah. Yeah. Does anyone have any other questions? Yeah. Okay.
So I have school-age children now, and they're both treated. They've both been treated for epilepsy, and they're weaned off medicine.
Okay.
But at the beginning, it was considered idiopathic, and they said, look, we're going to just say it's probably benign occipital childhood epilepsy, or it's benign toddlers.
Mm-hmm.
And that's supposed to be something that hits in around age 3. They both at 3 and 2 months developed it.
Okay.
But during their younger years, they had weird symptoms,
Mm-hmm.
which is why I thought something was off. But they're telling me that it wasn't epilepsy, so I'm trying to understand how to recognize the difference. Because they eventually went on to develop it. And one of the elder boys seems to be having absent seizures.
Oh.
Okay, and
Yeah.
so I'm trying to understand what it really is. And I'm the oldest in my siblings, and now starting to have children.
Mm-hmm.
So there's infants there. Of course, worried, both of my kids, and my sister's babies.
Yeah.
What would be the kind of symptoms you would see that aren't the classic shaking
Mm-hmm.
that you might be able to see? Like in my kids, looking at his eyes,
Mm-hmm.
or his pupils would be dilated in a way that I wouldn't expect.
Mm-hmm.
What kind of things could I remind myself to look at when I look at my sibling,
Yeah.
my nephews and nieces,
Yeah.
little ones,
Yeah.
if this were to happen to them?
Yeah. That's a great question. So seizures do tend to look different at different ages and for different kinds of epilepsy. And for every parent, the more you're worried about a seizure, the more you can sort of convince yourself that anything is a seizure if you're looking at it. So for newborns, it can be quite hard to know whether or not something is a seizure for a couple of different reasons. One is that an adult who has sort of classic epilepsy, a seizure might start in one part of the brain and then spread to the rest of the brain, and it usually lasts a couple of minutes. And within that spread, it's going to hit the part of the brain that controls your movements, and so that's why you see the shaking or the fall to the ground that goes along with the seizure. For newborns and for really young babies, they don't have the same connections formed yet, and so seizures may start in one part and just sort of stay there and never spread to the rest of the brain, so never spread to the part that controls movement. You don't get a nice, obvious shaking sign. Sometimes you do, but not always. The giveaway for newborns and young infants is usually that if they're having seizures, they have altered alertness or awareness. And babies do all kinds of weird staring, spacing off things. But it's still true that for babies, their seizures on average last for about 1 to 2 minutes. And so the baby who sort of stares off, but then you call their name and they turn around, I'm not particularly worried about that being a seizure. If it's that short, it's not likely to be a seizure. The baby who stares off and isn't responding to anything, and you can boop them on the nose, and they don't respond to the boop, they're still sort of staring off, that I'm more worried about being a seizure, and that's something that's worth checking into. When there's a family member who has epilepsy, and then there's a new baby, everybody's staring at new baby quite hard. And I almost expect to get a call about new baby and to do an EEG at some point. If nothing happens, if they don't scare anybody, that's great. But it's fair enough to check things out if there's anything that's worrisome. But the stuff that I tell family to do at the bedside is, for babies, seizures are most likely altered responsiveness. It's not enough to just call their name. They may be ignoring you. But if you get right in their face, if you boop them on the nose, if you pick them up and they're still having that glassy stare or the eyes rolled up or off to the side, that's worrisome. That's not normal. Most seizures in babies, their eyes are open and will either be rolled back or off to the side. Babies do lots of funny sort of twitches when they're sleeping. That's my favorite visit, is the baby who's twitching when they're asleep, because that's almost always normal and I get to give really good news. But if the eyes are open and the baby's unresponsive and there's funny movements or something like that, that's worth looking into a bit more. When kids are older, it's easier, because if you have a seizure that's in the back of the brain, for example, it may not be something that causes a motor sign for a long time, but kids are old enough to tell you that they're experiencing something, that they have a funny feeling, or that they see something funny, or they feel sick. It still may take a while to figure out that that thing was actually a seizure, but at least they're able to show you that there's something going on. And even if they can't put it into words, moms know. They'll say, he gets the look. Part of what makes a seizure is that it's often stereotyped. So I worry less about, on Tuesday he stared off, and on Wednesday he thought he heard something, and on Thursday there was a funny taste. Because it would be unusual for a seizure to show up in different ways each time it happened. But if it's the same thing every time, he gets the stare, the pupils dilate, and then I know he's going to throw up in 10 minutes, and it's the same every single time, then that's more worrisome for a seizure. By the time kids are older, like school age, sometimes they experience that stereotyped, that consistent sensation, and they may not be able to describe it because it's funny, but they can say, I'm going to have one of my seizures, I'm going to have one of my spells, and they can be really reliable for telling you it's happening, even if it's hard to put into words what the experience is. So coming back to your original question, I think for the other kids in the family, those are the things that I would say to look out for. For benign epilepsies of childhood, I think a lot of things that used to be just lumped into that category of, well, if you're 3 and you have seizures, it must be Paniatopolis. Or if you're a newborn and you have seizures, it must be benign familial neonatal seizures or fifth-day fits. I think as we learn more about epilepsy, we're learning that not everybody who gets thrown into that category has the same thing. And so for some kids, their seizures come back. For some kids, they really do just have an epilepsy syndrome that they'll outgrow. But if the seizures come back, it might be time to take another look at what's going on, because they technically wouldn't be expected to come back, particularly an absence type seizure. Yeah. Yeah, so when to do genetic testing. So part of it is when are you most likely to get an answer, and part of it is when is the genetic test going to be useful for the family. Thank you. So genetic testing has gotten pretty good for epilepsy, and it's now likely to give an answer for kids who have seizures that start before they're 3, particularly if the MRI doesn't show a reason for having seizures. It's more likely to give an answer when there's multiple family members who have seizures. Not always, but that's more likely. Sometimes people will try it in a kid where they're the only child who has epilepsy, knowing that it's less likely to give an answer, but it's possible. And the tests are changing so quickly that we tend to test kids every 5 years or so. So if they had genetic testing 5 years ago that didn't give an answer, we might retest now because there's just the tests are so much better. So that's sort of the when is it likely to be able to give an answer. The other part of it is when is that information useful? And that has a lot to do with how a family feels about genetic testing. And people are all over the map about that. There are some families who just don't want genetic information about their family for lots of reasons. And that's okay. I never tell someone they have to have a genetic test. There are some families who only want a genetic diagnosis if it's going to change the treatment that their child's going to get. And for most of the genetic epilepsies, we're not necessarily going to change treatment. It sort of depends on the situation that you're in. Sometimes we might, and there are some diagnoses, if I'm worried about it, I'll say, hey, I really want to know if he has this because it would change the medicine I use, for example. But for lots of the other ones, it's might be satisfying for knowing the why question, but it doesn't necessarily change the what do we do now question. And then for some families, there's a lot of value in just knowing, and knowing that you've looked everywhere that you can look, and not having the why question be a black box, and that's valuable too. So I think the when to think about genetic testing, I try to offer it for anyone who has seizures that start before they're 3, if the MRI doesn't give me a really clear reason for why they have seizures. I generally will offer it for kids who have epilepsy plus other unexplained neurologic problems, like epilepsy plus intellectual disability, or if you have epilepsy plus CP but a normal MRI, that's unusual, and that might be something where genetic testing could be helpful. For other kids, just sort of run-of-the-mill epilepsy, everything else is good. If a family's interested, I'm happy to order it, but I tell them up front that I'm not sure if it's going to give us information that's going to give a diagnosis or that's going to change our treatment. For insurance companies, every payer is different, and the kind of testing that they'll pay for is different. But there are a lot of really great nonprofits who will help connect families with programs to pay for genetic testing if that's an issue. There's some research studies where if you participate in the research study, you can get free genetic testing. Occasionally, I just can't get it paid for. But there are some avenues around that for families that want it and can't get it paid for through insurance. Yeah.
It changes your advice about when to stop a seizure medication. Like if the child has a genetic diagnosis and they're on a seizure medication and the seizure stops, say for months or even years,
Yeah.
do you think it changes that?
No, it's a great question. I mean, this is the question. Is this going to change what we're doing right now?
It might not change the initial treatment for seizures, but maybe it changes how aggressively you continue to treat if you're stable. Kind of like what you talked about with arrhythmia that really
It depends on which gene is involved. So there are some genes that cause epilepsy where I know if there's a mutation in that gene that the chance of that child having epilepsy lifelong is very high. And that's a situation where I would say, we should plan on this being the long-term plan. But there are other genes where even if you have a mutation in the gene, that never goes away, but kids still outgrow the seizures. So there's a potassium channel mutation, for example, called KCNQ2, that's notorious for this, where babies start having lots of seizures who have this condition. They often outgrow their seizures. They always have the gene change, and other people in the family might have the gene change and never have seizures. People can have the same gene change and have easy seizures or tough seizures. And so for genes like that, even if you get the diagnosis, it might not help me say whether or not someone's going to grow out of the epilepsy. So it really does come down to that gene by gene information that you get. I don't want to anger the timekeeper, so I'll stop there, but I'm around here, and then I'm going to be over at the Stanford table for if anyone has any other questions. Thanks very much, guys.